but you can see here that it's got a tiny little bend. And of course, when we introduce this into the canal and then we use it in T mode again, so this T mode is this reciprocation motion back and two, we can see now that this goes past that kind of ledge, and then once I've passed the ledge, T mode, you press the button again and it turns into a rotary action, and I'm just sort of automatically shaping out that kind of ledge or catch, which I think is the buccal cone. I start to place this GP cone in the buccal canal, and the first thing I notice, this is going really, really easily. In fact, I think that this GP cone is going past or beyond the mark where we've made. What I've realized that I've done is that I've picked up the wrong cone for the wrong canal. So this is actually the palatal GP cone. So I am going to very, very carefully and quickly remove this GP cone. So hello, welcome. Another Friday, another case, and you know, this is a great case. I do loads and I do God knows how many root canals every week, and I'm always looking out for a good case, a good kind of learning experience. And when I was doing this case, I was feeling the magic was happening, because I just felt like this was going wrong and we overcame that, and this was going wrong and we overcame that. So this is a really, really great learning case today. But before we get into that, what I want to say is, you know, 50% of the people who watch these videos are not subscribers. Okay, so we check the metrics on the channel from YouTube, and what I would ask you to do, it's quick, it's easy, and also, most importantly, it's free. You can just hit that subscribe button for me, okay? It supports the channel. If you hit the notification bell, that's even better. And if you want to take the support even further, you become a member. It's a small monthly fee. If you love these videos, you get early access to content. So I'm usually 3 or 4 weeks ahead. So you get to watch the videos earlier than everybody else. And also there's exclusive content. So we've got a fantastic access, root canal access video on the membership only page. And it's based on a lecture that I do on access. So it's a fantastic resource. So we'll get in with the case. Weirdly enough, this is actually a case of an upper left 5. And I work in a few practices, but in one of the practices one day we had a patient who was in pain and their normal dentist wasn't in, and I got to see them. And when she presented to me, she had the buccal wall of this upper left 5 was missing, although after all the special tests, clinically we checked as well. I thought that the tooth was reversibly inflamed, and in the first instance I just said to the patient, you know what, let's just put a composite filling on it and see how we got on. Subsequently they went to the dentist, they were having symptoms, and it found out it wasn't reversible pulpitis, it was irreversible pulpitis. So she's come back to me, and she's come for the root canal. But when we look at this x-ray, we're kind of thinking to ourselves, is this x-ray or is this tooth got 2 canals, or has it got one canal? And to me, it's obvious now that it's got 2 canals. But at this point, sometimes when you're looking at x-rays, you know, you can see the kind of radiographic presentation of the bone. It's not so obvious. I think a bit of a red flag for me is that the canal space disappears. And when it disappears further down the root, it usually means there's like a bit of a split, or there's complexity. Okay, so the first thing we're going to do is we're obviously going to place rubber dam. That's really, really important. Obviously, like, use the clamp with the dam at the same time, give it a little bit of a wiggle to make sure it's nice and on, and then I'm going to remove the temporary fills with a fast hand piece and just a normal sort of torpedo burr. And sometimes when I'm removing temporary filling materials, the water gets on my mirror, so I always like to have a little bit of paper roll on the corner there, so I can give my mirror a little bit of a wipe. But I'm going to use a DG16 endodontic probe to remove this dressing. So this dressing was actually placed by her normal dentist. I'd done the composite filling buccally, but he'd accessed this tooth, and he's pretty good, this guy, because he uses PTFE just just like me. So once we've removed the dressing, it's looking a bit nasty inside the pulp chamber, so I'm going to use an ultrasonic tip here. I like to use these kind of perio tips, mainly because they can get into the canal space nice and easy, but the problem with perio tips is the thinner they are, the less energy they have, so it's kind of a bit of a way up. Once we've cleaned out the canal space, I think the palatal is pretty wide, so I'm going to just pick up my apex locator straight away. You'll notice there's no fancy screen on this because my nurse have broken it. Luckily, with these Wirelex apex locators, the kind of little Bluetooth little dongle that sits on there works as an apex locator as well. So I'm in the process of buying a new apex locator. But before I do the apex locator reading, I'm going to irrigate, and what I like to use are these Irriflex side venting Irriflex tips, and they sort of side vent, as you can see here, but also because they're quite flexible, they get right down into the canal space. So we give it a good old irrigation there. Once we've filled the cavity up with irrigants, I'm going to pick up a size 10 K file, and then we're going to try and attempt to get 0. And I have a little fiddle around with this, and I can't quite get to 0 in this case. So what I'm going to do is I'm just going to move the rubber stopper to as far as I can get, and then I'm going to measure that, and then that's going to be our area of reference when we're going to be shaping the coronal to mid-third. So again, we just adjust the stopper, and then the furthest point we can reach here is 19 millimeters. So in my mind, I'm thinking I'm nearly to the end. If I'm at 19, I'm nearly to the end. So I'm going to get a size 1403 glide path file. This is a high flex, and I'm going to shape this to 18. So this is minus a millimeter away from the furthest point reached. And then in this particular case, I'm going to get a size 2004, and I'm going to shape this to 17. Don't be tempted to push this any further. Just do things in a nice process, and just make sure you're just shaping things and you're not just trying to rush things. So this is essentially what we're trying to do. We're trying to release the grip of the canal space around the file so it negotiates. But before we try to negotiate even further, what I'm going to do is I'm just going to work out if these two canals join, because I'm not too sure. And what I'm doing is I'm putting the Irriflex tip in one of the canal spaces and irrigating and aspirating. And although here it kind of looks as if it's irrigating and aspirating at the same time, when we look really, really closely at the buccal, it's still full of irrigant. So I'm not too sure if they are separate or not separate, but we just need to keep our sort of mind on that. I mean, this could be where they just joined apically, and the sort of surface tension of the water just can't pass through yet until we've given it a good old clean out. So then to negotiate down the palatal, I'm going to pick up a D-finder, okay? These are kind of smooth bore files, they're narrow, and then I'm going to measure this up to 21. So rather than 19, I'm going to measure it a little bit further, because when I'm sort of negotiating down there, if the stopper is sort of moving towards the cusp, I know that I'm negotiating and I'm getting a little bit further without hooking it up to the apex locator. And the stoppers are symmetrical, so you don't really know where the bend is, the bend that you're going to make. So what I like to do is just snip off the sort of apex of one of the triangles, and then do the bend where I've snipped it off, so I know exactly where I'm kind of negotiating with this. Because if you get the hand file through the bend, you want to know in which orientation this bend is sort of moving. So you can see here that we've got a nice little bend on the end of this, and I'm just going to really, really slowly negotiate this into the palatal. And I notice now that it is advancing quite nicely, and when we hook it up to the apex locator, we're now at 0, so it's a really, really nice, we've followed a set protocol, and now we're to 0, and that's very, very satisfying. So we're just going to push the hand file out and then back it up. We're going to kind of notice where this bend is. So this bend is kind of moving towards the buccal. So again, another sort of thing that I'm thinking, do these two canals join? So just, again, always keep your wits about you. You just want to think about every eventuality so you don't make any mistakes. We do the working length of the palatal, and it's found to be 20 millimeters. So I'm going to get a size 10 K file, and I'm going to measure this up to 20 millimeters. I'm not going to go straight for the glide path file at the moment, because I just feel like getting the 8 to length was quite difficult, and I think going from an 8 to a 15 is probably a bit too hard. So I'm just going to use a size 10 just to sort of keep that canal space patent and sort of, increase the diameter slightly. Once we know the 10's gone straight to length, I'm going to use a size 15 glide path file here. And then again, it's being really, really, really careful, not pushing this too much. If you're getting a bit of resistance, pull out, irrigate, recapitulate. So again, I'm going to use the same file that I used to get 0 to recapitulate with, and then just do more shaping. So in the first sweep of the glide path file, I was getting a little bit of resistance, so I pulled out, and now we're going to get to length really, really nice and easy. And again, recapitulation. We're now going to do our final shaping with a size 20 file, and we're going to do it at 19.5 millimeters. And this isn't quite reaching 0, so again, I'm not going to push this too much. I'm not going to just force this because you're going to cause a ledge. I'm just going to recapitulate with a size 10 K file. This is all in the Palatal, by the way. And once we've recapitulated and we've irrigated, the 20 is now reaching 0. I'm a little bit reluctant to use anything higher than a size 20 in this case, because I just think the roots are quite spindly, they're quite small, and I found it really, really difficult to get to the end. So using maybe like a 25 probably will pushing our luck slightly. And again, I'm just having a little look at aspirating and irrigating the Palatal and just seeing if the Buccal aspirates and irrigates at the same time. And again, it doesn't. So that's not to say that they don't join, because again, maybe we're going to shape the Buccal and we find out that they do join. But again, it's moving towards that maybe these have got 2 separate canals. And that is significant. If it isn't obvious to you, it's significant, because when you come to obturate this tooth, you need to know if they join or not. We're then going to attempt to get our 0 reading on the Buccal, and I'm going to use a size 8 D-finder here with a small bend. And as I sort of reach this, I'm getting significant resistance. And when we hook up the apex locator, it notices that I'm not really getting to length. And what I'm trying to do here is I'm trying to negotiate a little bit further, but I'm getting a bit stuck. So we notice that the furthest point reached with this D-finder is 21.5 millimeters. So again, we're kind of really, really near to the end. And I'm just going to use a size 10 to about the same amount to try and increase the size of this coronal to mid-third in the Buccal, just to give it a little bit of a shape. But as I push this size 10K file to length, I'll notice that as I sort of move it up and down, I'm getting a ledge. So I'm not getting even close to 21.5 millimeters like I did with the size 8. And the worst thing to do now is to make the ledge worse. Work out that you have a ledge, and to get past this, we're going to make a little bend at the end. Now, this ledge has been unlikely been caused by me. It's probably just like an anatomical anomaly. It might be just kind of like a catch or whatever. But the principle is the same as with the ledge. I'm going to make a small bend at the end with this little size 10K file, and I'm going to slowly move the ham file around in a 365 degree motion, trying to feel for that kind of point where we can get the ham file past, and we can see that we've got it past here. Worst thing to do now is pull it out. You're just going to be moving the ham file up and down nicely, up and down, and you'll notice that when you put a lot of pressure on these files, they kind of lose their bend. And also, you just got to be careful for file fracture. So always maintain the bend, just pull it out, give it a little bend, just check the end to see if any of the flutes are unwinding. That's another sign that the ham files are about to break. If you're seeing flutes unwind, you just swap the ham file and then just introduce it again. And despite me sort of trying to sort of file out this ledge, when I pull this hand file in and out, now I can see that I'm still got this kind of sort of significant kind of catch here, and it's getting a bit stuck. So again, worst thing for you to do here is to ram the file down in there, because you're going to make this ledge or catch worse. We're going to take the ham file out. We're going to start with doing lots and lots of irrigation. Again, we're going to just maintain the bend. We're just going to get the ham file. We're going to make a small bend at the end. And then it's the same protocol. We're going to just use that bend to negotiate around this ledge or catch. Again, I think with all these kinds of issues is that you just got to keep your patience. I know sometimes, practice life can be busy, but, if you make a significant ledge worse, it's going to make you more busy, okay, because you can have more problems. And you'll notice here that I am, after shaping out the canal space, I'm actually negotiating past this 21.5 millimeters. The stopper's going past the sort of the cusp, and when we hook up the apex locator, I'll notice that I'm a bit further towards 0. So I'm just having a little fiddle around and moving it in and out, and then finally we get 0 on the apex locator. And you might ask yourself, why has the size 10 got to 0 but the 8 didn't? It might be because the higher tape has shaped the canal space and stopped the gripping, or maybe the size 10 is stiffer than the 8. But essentially, who cares? I've got to 0. And it's another one of those hurdles that I've overcome. So again, I'm just going to make sure I'm at 0. I'm going to adjust the stopper, and when we measure the buccal, it's found to be 22 millimeters, and it's only 0.5 millimeters away from the furthest point reached originally with the size 8. So a lot of these times you're probably just not that far away from 0, and so again, it's another sort of vote for patience and taking your time. Same again though, we're just going to get past that ledge, going to give a bit more of a clean out with our hand files, and then I'm going to try and automate the removal of this ledge a little bit using a glide path file. And the first glide path file that I do use, this is a Hi-Flex 1503, and the problem with these Hi-Flex glide path files is they don't they've got a little bit of shape memory. So have you noticed before with the hand files, I had to make a little bend at the end to get it past the ledge. But what I am going to do here is I am going to try and use this glide path file in T mode, so it's kind of that automatic kind of reciprocation mode. And then when I introduce this 1503 into the buccal canal, you'll notice that it gets a little bit stuck. And again, if I say this once, say 1,000 times, if you're getting stuck on a ledge, don't force the file. You're either going to fracture or you make the ledge worse. Okay, so just really be mindful here. This T mode is sort of going back into, but I'm not pushing this because I know it's not going anywhere. So I've got a pack of these Toothsaver 1403 glide path files, and I really like these glide path files because what you can do is you can get a small bend at the end with these files. It hasn't got complete bendiness, and it doesn't keep its shape when you do bend it as much, but you can see here that it's got a tiny little bend. And of course, when we introduce this into the canal and then we use it in T mode again, so this T mode is this reciprocation motion back and 2, we can see now that this goes past that kind of ledge, and then once I've passed the ledge, T mode, you press the button again and it turns into a rotary action, and I'm just sort of automatically shaping out that kind of ledge or catch. And then always recapitulate. That's really important. And you'll notice now that this hand file is actually moving up and down really nice and easy. It's not so much getting caught on this ledge. And then we're ready for the 20 master apical file. And this is a Hi-Flex. And the great thing about these, you can also put a bend in these. So I'm going to just shape it to 21.5, so 0.5 millimeters away from the 0 reading. I'm going to make a tiny little bend at the end, and then I'm just going to use this in T mode again. And sometimes it can be a bit difficult, but I know at the point where the sort of ledge or the catch was, it's about 18 millimeters. And then what I'm going to do is I'm just going to put it in T mode until we get past, and then I'm getting a little bit of resistance here. So I'm going to pull out. And what I noticed is when I pull out is there's a lot of debris on there, and I'm just checking the end because this file has taken a lot of brunt. We're going to recapitulate and re-irrigate. Remember to remove the debris off this file. We use a little sponge. And then again, we're going to just repeat these actions until we're shaping at the end. And don't forget, you really struggled. I really struggled to get to the end here. So what I'm not going to do is I'm not going to push these rotary files too hard to length. I'm just going to couple of pecks, pull it out, irrigate, recapitulate, a couple of pecks, and we can see now that it all looks really, 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 really nice. We've got 2 obvious canal spaces here, and I suppose in a way, when we were irrigating and we were aspirating our irrigant, I noticed that both the canals were weren't irrigating and aspirating together. So what I'm going to try to do now is I'm going to assume that there are 2 separate canals, and we're going to do our cone fit radiograph. And in this case, what I like to use is these maximum diameter GP cones. So these are 2004 at the end, but they have a maximum diameter of 1 millimeter. So these are never going to go wider the 1 millimeter. Problem with these is they're very, very friable at the end. So when you pull them out, you want to have a little look at the end to see if they're bent. So the first one there was a bit bent, so I'm not going to use that. I'll put that to one side. And then another thing I've noticed about really, really small and friable GP cones is that sometimes the tip diameter aren't correct. So a thing that I've started to do now is I've started to just sort of check the ends. And so if I use this gutter cutter here and I'm pushing it in the size 20, you can see a little bit of the GP is poking out the end. And now that cone is now a proper 20 at the tip. And I'm just going to check the other one, and we can see here that this is also sort of poking out the end. So the tip isn't 20. Although, you know, I've used this pack lots, and, you know, more often than not, they are 20, but it's always important just to check. We're then going to place the buccal cone at 21.5 millimeters. So I'm just going to use this measuring block here just to work out where the measurement should be. And then I place this GP cone really, really, really gently to length. And then once we've sort of felt for that kind of snugness and we've checked that the working length is correct, we're then just going to snip the excess off right at the end. Once we've placed the buccal cone, we're going to just measure again the palatal, which is 19.5 millimeters. And we, again, do the same sort of process. We're going to fit it really, really nicely to length, get a little bit of tug back, and then snip off the excess. And when we look at the cone fit radiograph, it looks really, really, really nice. Really nice. Now it's obvious that there are 2 canals. They're at the working length. And we've got a really, really nice narrow taper. So I'm happy that we're ready to go for our final obturation. Whilst the X-ray is developing, however, I'm going to fill or prepare ourselves ready for the obturation. So I'm going to fill these wells with sodium hypochlorite, and then I'm going to use a different well to fill this with EDTA. And then I'm going to place some isopropyl alcohol. And the reason why we use this will become apparent later on. And then I'm just going to remove the GPs from the canal space, and then we're going to dip these and disinfect these into the bleach. We're then going to get a hand file. We're going to measure it to about 18. Maybe this is about 2 or 3 millimeters away from the working length, and then we're going to disinfect that because we're going to use that later for our obturation. And then we're going to use our final disinfection protocol. I'm using this 18th Ultra X ultrasonic activator. So what this does is it ultrasonically activates the irrigant we're using, and you'll notice that this works really, really well because you're irrigating with your sodium hypochlorite. I'm going to use it on full power, by the way, and you'll notice that we get this kind of like pond water. It starts to go a bit of a grey colour, and you know that you're removing all that kind of debris off the canal walls. And we're using sodium hypochlorite activated, EDTA activated, and a final rinse with sodium hypochlorite. We're ready to do our final drying. I'm using these Wave 1 Gold paper points. I'm not too worried that they're a different taper and not going to get to length because I know they're drying. And then we're ready to prepare our GP cone. And I want you to try and spot the mistake that I've done here. So I've picked up the GP cone from the Buccal well, and then I'm going to dip it in some isopropyl alcohol. This removes the residue of the sodium hypochlorite, which apparently affects the obturation. And then we're going to place that to one side. That's ready to pick up. And then we're going to pick up our Bioceramic. I'm using these visco tips here. And then I am going to fill the buccal canal. So we're going to directly inject Bioceramic into the Buccal canal. I then pick up our disinfected ham file, dry that off again in the same way, and I'm going to introduce this ham file to almost the working length, and this is going to introduce the Bioceramic into the canal space. I then pick up which I think is the Buccal cone. I start to place this GP cone in the Buccal canal, and the first thing I notice is that as I push this Buccal, this GP cone to length, this is going really, really easily. And in fact, I think that this GP cone is going past or beyond the mark where we've made. And I'm thinking to myself, you know, why is this happening? Is there something wrong with the cone? And what I've realised that I've done is that I've picked up the wrong cone for the wrong canal. So this is actually the Palatal GP cone. So I am going to very, very carefully and quickly remove this GP cone. You know, I could just fit it to length, but I know that this fits really nicely in the other canal, so I don't want to tempt fate. I'm just going to pull it out very quickly. I'm going to put that to one side, and then going to quickly prepare the correct GP cone by dipping it in isopropyl alcohol, give it a bit of a dry, and then I'm going to place this in the correct canal. And then very, 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 very gently, I'm going to push this GP cone to length, and we can see now that this is reaching the correct mark where it has been snipped off. I'm not then going to just remove any of the excess, because I have pulled out a cone and this has got sort of bioceramic around it and there's a risk of it drying and possibly not getting to length. I'm just going to very, very quickly and efficiently just fill the Palatal canal, and again introducing this ham file. I'm going to pick up the said GP cone and I'm going to fit this really, really nicely to length. Sometimes you'll notice that you know, despite the bioceramic taking 4 hours to set properly, in this case, sometimes you can get kind of like a bit of a residue on this if you've used, you get a little bit on the cone, and I didn't want to make that an issue trying to get it back in the other canal. So I just wanted to get it in the canal as quickly as possible, and then we're just going to remove the excess with our heated plugger. I like to remove the bulk of the excess first, then I like to get a Mach 2 plugger, and then I like to just kind of push down these cones and condense all of the GP and the bioceramic into the two canal spaces. And then I do like to give it a bit of a clean out to see what we've got left. And then sometimes what I do need to do is tidy this up, because this doesn't look too great at the moment. So I'm just using a heated plugger to kind of just remove a 2 or even 1 millimeter of the GP away from the sort of coronal aspect. So we get that kind of maybe the GP cones are sitting maybe 1 or 2 millimeters below, and then now, you know, this obturation is looking a bit tidier, and I'm going to use a little bit of Scotch Bond, drying, curing. Scotch Bond is self-etching, by the way, and then I'm going to use some SDR. This is like a bulk flow composite, and then we look at the X-ray. It's beautiful. It's always beautiful, but this one's particularly beautiful. I'll tell you why I like this. I think it's got a really nice minimal prep. So we've kept the integrity of the crown as much as possible. I like that we've used a minimal prep. I like that we haven't had any kind of sealer puff. You know, sealer puff, it isn't the end of the world, but I just like to try and confine it to the end of the root canal. The obturation is to the end, and it looks absolutely fabulous. And that's it. Listen, if you like the video, again, please like and subscribe. Hit the notification button as well. If you want to take that support even further, join the membership program. We've got loads of videos on there for you. And if you have any criticisms or comments, please comment in the section below. And I will see you in the next video. Bye-bye.